Put your hand on your knee right now. Go ahead. Just rest it there for a second. Feel that? Maybe a dull ache. Maybe a stiffness that wasn't there 5 years ago. Maybe nothing right now, but you know it's coming. You felt it on stairs. You felt it getting out of the car. You felt it in the morning when you take that first step out of bed and your knee reminds you, loudly and without apology, that something has changed. Now let me ask you something. What did your doctor tell you when you brought it up? I'm guessing it was one of 3 things. Rest it. Lose some weight. Or here's an anti-inflammatory. Come back if it gets worse. And maybe you nodded. Maybe you filled the prescription. Maybe you went home and did exactly what they said. And maybe, it helped a little. For a while. And then it came back. Because it always comes back. Here's what your doctor didn't tell you. And I say this not to criticize my colleagues. I say it because the appointment was 12 minutes long, the waiting room was full, and what I'm about to share with you takes longer than 12 minutes to explain properly. 20 years of clinical practice. And knee pain, this extraordinarily common, frequently dismissed, deeply misunderstood condition, is one of the things I am most passionate about setting straight. Because I have watched too many people limp through the second half of their lives, believing nothing could be done. Believing the pain was just their fate. Believing the only road ahead was a knee replacement, and a long recovery, and a life edited down to whatever their knees would allow. That is not the whole story, not even close. And today, I'm going to tell you the rest of it. Let's start with the thing that almost nobody tells you. The thing that fundamentally changes how you understand knee pain from this moment forward. Your knee is not the problem. I'll say it again because I need it to land. In the majority of cases, the vast majority, your knee is not the origin of your problem. It is the victim. It is the structure that is suffering the consequences of imbalances, dysfunctions, and stresses that are happening elsewhere in your body. And when you treat only the knee, when you ice only the knee, inject only the knee, eventually replace only the knee, without addressing what caused it to break down in the first place, you are treating the smoke alarm instead of the fire. Let me explain exactly what I mean. Think of your body as a kinetic chain. Everything is connected. Your feet connect to your ankles to your knees to your hips to your spine. When one link in that chain is weak, misaligned, or dysfunctional, the links above and below it absorb extra stress. They compensate. And joints, particularly the knee, which is one of the most mechanically complex and load-bearing joints in the human body, are not designed for chronic compensation. They tolerate it for a while, sometimes for years, and then they stop tolerating it. So when I see a patient with knee pain, I don't start at the knee, I start at the feet. Are you overpronating? That means your arches are collapsing inward when you walk or stand. This creates a medial rotation force that travels directly up through your ankle and lands, hard, on the inside of your knee. Millions of people walk like this their entire lives and never know it. They don't feel it in their feet. They feel it in their knees. Then I look at the hips, and this one is the biggest one. This is the one that changes everything for so many of my patients. Weak hip abductors and weak glutes, the muscles on the outside and back of your hip, are among the most common and most overlooked drivers of knee pain in existence. When these muscles are weak, your femur, your thigh bone, drops inward during every step you take. Every single step. That inward collapse places enormous asymmetrical stress on your knee joint, compressing the cartilage on the outer edge and grinding structures on the inner edge. Over thousands of steps a day, over months and years, this destroys knees. And here's what makes it insidious. The person experiencing this rarely feels weakness in their hip. They feel pain in their knee. So they focus on the knee. They rest the knee. They ice the knee. Their hips get weaker from the rest, and the knee gets worse. This cycle, this completely avoidable, completely reversible cycle, is one of the great tragedies of how we approach musculoskeletal medicine. Now let me introduce you to someone. His name is Robert. 63 years old, former electrician, spent decades on his knees, literally, crawling through attics, crouching under floors, climbing ladders. By the time he came to me, he had been told by 2 different orthopedic surgeons that he needed bilateral knee replacements. Both knees. He was on a waiting list. He was taking ibuprofen daily, which, by the way, I want to talk about separately because daily ibuprofen use carries risks that most people don't fully understand. Robert came to me not because he believed I could fix his knees. He came because his wife found my content online and made him come. He sat in my office with the energy of a man who had already accepted his fate. He showed me his MRI. Significant cartilage loss in both knees. Real damage. I'm not going to pretend otherwise. But I asked him something his surgeons hadn't asked. I asked him to stand up and walk across the room, and I watched him. Just watched him. His feet were pronating severely. His knees were collapsing inward on every step. His trunk was swaying side to side, compensating for hip weakness so profound that it was visible in his gait from across the room. This man was loading his damaged knee cartilage with forces far beyond what was necessary, with every single step, because of biomechanical dysfunctions that no one had ever addressed. We didn't cancel his surgery, but we postponed it. For 6 months, Robert worked with a physical therapist on hip strengthening, glute activation, gait retraining, and orthotics for his pronation. We addressed his inflammation through dietary changes, and we stopped the daily ibuprofen. At the 6-month mark, Robert called my office. He wanted to push the surgery back further. He was sleeping through the night for the first time in 2 years. He was walking his dog every morning. His pain, on a scale of 1 to 10, had gone from an 8 to a 3. He has not had the surgery. That was 14 months ago. Now, and I want to be very careful here because I don't want anyone to take this as a blanket statement against knee replacement surgery. Knee replacement is a genuinely life-changing procedure for many people. When cartilage is severely destroyed, when conservative measures have been truly and properly exhausted, surgery can restore quality of life in ways that are remarkable and real. What I am saying is that it is being recommended in some cases before the conservative measures have been truly and properly tried. And you deserve to know that. Let's talk about cartilage. Because there is a myth about knee cartilage that has been repeated so many times for so many decades that most people, including many doctors, believe it completely. The myth is this: cartilage cannot heal. Once it's gone, it's gone. This is not entirely true, and the nuance matters enormously. Cartilage is avascular, meaning it has no direct blood supply. This is why it heals slowly. This is why severe cartilage damage is very difficult to reverse. But cartilage is not static. It is living tissue. It receives nutrients through a process called diffusion from the synovial fluid that bathes the joint. And the quality and composition of that synovial fluid, the health of the joint environment, has a significant impact on cartilage maintenance and, in early to moderate damage, some degree of repair. What promotes healthy synovial fluid and supports cartilage? Movement. Specific, appropriate, low-impact movement. Not rest, not immobilization, not sitting still because it hurts. Gentle, cyclical movement, the kind that pumps nutrients into cartilage without overloading it, is literally how you feed your knee joint. This is why swimming is so powerful for knee pain. This is why cycling, properly set up so the seat height is correct, is therapeutic rather than damaging. This is why walking in a pool, which offloads a significant percentage of your body weight while still providing movement, is one of the most underutilized interventions for knee osteoarthritis. And here's what nobody tells you about complete rest when your knee flares up. Short-term rest to calm an acute flare. Absolutely appropriate. But prolonged rest causes muscle atrophy. Muscle atrophy removes the protective dynamic support from your knee joint. And a knee without muscular support is a knee that deteriorates faster. The very thing people do to protect their knees, resting for weeks, avoiding all activity, can actually accelerate the breakdown. Move your knees, but move them smartly. Now, let's talk about inflammation, because this is where things get really interesting, and where a surprising truth emerges that most people have never considered. Knee osteoarthritis was for a long time considered a mechanical problem. Wear and tear. Cartilage grinds down, bone rubs on bone, pain results. Simple mechanics. But research over the last 15 years has fundamentally shifted that understanding. We now know that inflammation, systemic, whole-body inflammation, plays a central and driving role in knee pain and cartilage breakdown. This is not just inflammation inside the joint. This is the low-grade, chronic, body-wide inflammatory state that is driven by diet, gut health, metabolic function, and lifestyle. And this means something profound. It means that what you eat affects your knees. Not metaphorically, not loosely, directly, measurably, biologically. A diet high in ultra-processed foods, refined sugars, and industrial seed oils drives up inflammatory markers, including interleukin-6 and TNF-alpha, that directly contribute to cartilage degradation. Studies have found that people with higher blood levels of these inflammatory markers show significantly faster progression of knee osteoarthritis. Conversely, a diet rich in omega-3 fatty acids, found in fatty fish like salmon, sardines, and mackerel, has been shown to reduce joint inflammation and decrease the need for pain medication in people with knee osteoarthritis. This is not supplement marketing. This is peer-reviewed biology. Collagen peptides. Let me address this because I get asked about it constantly. The research here is genuinely promising, and I say that as someone who is extremely cautious about supplement claims. Multiple randomized controlled trials have shown that hydrolyzed collagen supplementation, combined with vitamin C, which is essential for collagen synthesis, can reduce knee pain scores and improve joint function in people with osteoarthritis. The mechanism makes biological sense. You are providing the raw materials your body uses to maintain cartilaginous tissue. Am I saying collagen supplements are a cure? Absolutely not. Am I saying there is legitimate scientific support for their use as part of a comprehensive approach? Yes, I am saying that. Vitamin D. This one matters more than most people know. Vitamin D receptors exist on cells throughout the musculoskeletal system, including in joint tissues. Vitamin D deficiency, which is extraordinarily common, affecting an estimated 1 billion people worldwide, is associated with increased pain sensitivity, increased inflammation, and faster cartilage loss. If you have knee pain and you don't know your vitamin D level, you need to know your vitamin D level. Ask for it at your next blood draw. Now I want to spend a moment on something that I think is the most emotionally loaded aspect of knee pain. And I need to handle this carefully because I don't want anyone to feel judged. But I would not be doing my job if I didn't say it. Body weight and knee pain have a relationship that is real, measurable, and significant. The knee joint transmits forces of 3 to 6 times your body weight during normal walking. This means that 10 extra pounds of body weight translates to 30 to 60 additional pounds of force on your knee joint with every step. Over thousands of steps a day, over years, this accumulation is not trivial. But here's the part that is rarely discussed alongside the weight conversation, and it's critical. Adipose tissue, body fat, particularly visceral fat, is not inert. It is metabolically active. It produces inflammatory cytokines, those same inflammatory molecules we just discussed. This means that excess body weight contributes to knee pain not just mechanically, through increased load, but chemically, through increased systemic inflammation. The two mechanisms compound each other. And this is why weight loss, even modest weight loss, can produce disproportionately large reductions in knee pain. A 10-pound weight loss reduces knee load by 30 to 60 pounds per step. Multiply that across an entire day of walking. The relief is cumulative and significant. I say this not to make anyone feel bad about their body. I say it because it is actionable. It is something within your influence. And knowing the mechanism, knowing that it works through both load reduction and inflammation reduction simultaneously, makes the effort feel meaningful rather than just cosmetic. Let's talk about injections, because this is another area where I think patients deserve more transparency than they sometimes receive. Cortisone injections, extremely common, often very effective for short-term pain relief, and I do mean short-term. What is less commonly communicated is that repeated cortisone injections may actually accelerate cartilage breakdown over time. A study published in JAMA found that patients receiving regular cortisone injections showed significantly greater cartilage volume loss over 2 years compared to those receiving placebo injections. This does not mean cortisone injections are never appropriate. They absolutely can be, for acute flares, for buying time to implement other interventions, for specific clinical situations. But receiving them repeatedly, every few months, year after year, as a primary management strategy, the evidence suggests this may be trading short-term comfort for long-term structural damage. Hyaluronic acid injections, sometimes called gel injections or viscosupplementation. The evidence here is mixed, and I'll be honest with you about that. Some patients report meaningful benefit. Large meta-analyses have been less convincing. They are generally considered low risk, but they are also not a guaranteed solution, and the marketing around them sometimes outpaces the science. Platelet-rich plasma, PRP injections. This is a newer and genuinely exciting area of research. Early data suggests that PRP, which involves injecting concentrated growth factors from your own blood into the joint, may have real regenerative and anti-inflammatory effects in knee osteoarthritis. It is not yet standard of care, it is not yet universally covered by insurance, and we need more long-term data. But I am watching this research closely, and I think it represents a meaningful frontier. Now, before I give you your action plan, there's one more thing I need to address. Because I promised you things your doctor doesn't tell you, and this last one might be the most important. Mental and emotional health affect knee pain profoundly, measurably. This is not me being philosophical. This is neuroscience. Pain is not purely a peripheral signal. It is a perception constructed by the brain. And the brain's pain modulation system, the way it amplifies or dampens pain signals, is directly influenced by psychological state. Depression, anxiety, chronic stress, social isolation, and poor sleep all increase central sensitization, which means the nervous system becomes more sensitive, more reactive, more likely to interpret signals as painful. Studies have consistently shown that people with knee osteoarthritis who also have depression report significantly higher pain levels than those with equivalent structural damage, but without depression, even when their MRIs look identical. This is not imaginary pain. This is real pain, real, felt, suffered pain. But it has a component that exists in the nervous system's volume control, and that volume control responds to treatment. Cognitive behavioral therapy has been shown in clinical trials to reduce chronic pain scores in knee osteoarthritis. Sleep treatment reduces pain sensitivity. Social connection reduces pain. Exercise, which we've already discussed for its mechanical and anti-inflammatory benefits, also profoundly improves mood and modulates the brain's pain processing. The knee is connected to the body. The body is connected to the mind. You cannot treat one without the others and expect the best possible outcome. So here is your action plan. Concrete, practical, and starting today. Get your hips assessed. Ask your doctor for a referral to a physical therapist who specializes in musculoskeletal assessment. Ask them specifically to evaluate your hip abductor strength and your gait mechanics. This single step may reveal the real driver of your knee pain. Look at your feet. If you don't know whether you overpronate, wet your foot and step on a piece of paper. If your footprint shows almost no arch, your entire inner foot touches, you are very likely overpronating. A pair of proper orthotics or supportive shoes may change your knee mechanics significantly. Reduce your inflammatory load. Start with one change. Cut out daily consumption of ultra-processed food and replace it with something whole and real. Add 2 servings of fatty fish per week. These are not dramatic changes. Their effects on joint inflammation done consistently are real. Know your vitamin D level. Ask for it. If you're deficient, supplement under medical guidance. Move in water, even once a week. Pool walking, swimming, aqua aerobics. Your knees will tell you the difference within a month. And most importantly, if you've been told you need a knee replacement, ask for a referral to a good physiotherapist before you schedule the surgery. Ask your surgeon directly, what conservative measures should I try first, and for how long? A surgeon who respects your question will give you a real answer, and that answer might give you back your knees without an operating room. Your knees carried you here. They walked you through every year of your life, every floor of every building, every path in every park. They deserve more than a 12-minute appointment and a prescription. They deserve the full story. Now you have it. Share this with someone who is living with knee pain and has been told there's nothing to be done. Because there is something to be done. There is almost always something to be done. And if this video helped you, if even one thing I said today opened a door that felt closed, subscribe and stay close, because I have so much more to tell you. Take care of those knees, and take care of yourself.